Good evening, everyone. Thank you for joining me for Kaplan's fourth and final webinar in our series focused on racial inequality in medicine. My name is Natisha Smith, and I am your host this evening as we talk about an important, challenging, and given everything that 2020 has thrown our way, timely topic, racial disparities in mental health care. Joining me to talk about this topic tonight is our esteemed panel, which includes Dr. Tiffany, a licensed clinical psychologist, the highly esteemed Gabrielle Davis, who is a licensed professional counselor with a master's in public health, and who also recently can add that she's the owner of Actionable Counseling and Consulting based in Boise, Idaho. Congratulations again, Gabby. Still very excited about that news. Sandrine, sharing her years in social work. Dr. Michelle, a resident of psychiatry at Texas Tech Health Science and Center in El Paso. And last but definitely not least, Kavisha, joining us as a third-year medical student. How are you all doing this evening?
Good. Well, thank you.
I want to thank all of you for joining me during what is honestly a weird week. I think we should sort of address the elephant in the room, which is we are all still awaiting some pivotal decisions about the future of our nation. And so I know that this is a challenging time for many of us, and a time in which our mental health is front and center. And so we really appreciate the opportunity to have this conversation. As we think about everything 2020 has brought our way, something that stands out is simply that prioritizing mental health is a new concept in many spaces, and particularly in communities of color and for individuals of color. Leveraging therapy, taking medicine, viewing mental health care as important as physical health care has historically been taboo in communities of color. So to kick us off, I think it's really important that we first just talk about where the myths and understandings around mental health come from in communities of color, and what are the current cultural conversations around this important topic. Dr. Tiffany, I want to start with you. As you think about what are the cultural factors that impact the view that communities of color have on mental health, what are some of the things that really stand out to you that have made an impact and have created this narrative?
I think that traditionally the idea of going to therapy or seeking mental health treatment, it has been thought that that's for a certain group of people. It's been thought that that's the white thing to do. But what's interesting is people of color, Black people, we've been talking, forever. We talk to elders, we talk to people in the church, we talk to family members. But what has happened is we haven't gotten used to doing that in a professional context because it was thought that that's for white people. So there's a thought that it's only for a certain group of people. And then we also have some distrust around systems. And we know all the reasons that there is this distrust around systems. But oftentimes seeking mental health treatment, it's associated with systems. And those are systems that historically haven't treated African Americans or Black people or people of color well. So we're still working on improving the ideas that people of color or communities of color have around those systems.
Dr. Michelle, I know that this is something that comes up for you in your space, in your work, of just navigating the barrier of people not viewing, I think to Tiffany's words, mental health as for them, for their community, viewing it as something that is not aligned with their needs. How is that showing up in your space?
There seems to be this mythology about how certain groups of people, especially minorities, should be able to kind of pull themselves up by their own bootstraps, toughen up by themselves. And that, seeking that kind of help is a sign of weakness or some sort of organic disorder. And so that pathologizing of actually asking for help really is a detriment to these communities because, if we can find a way to make mental health care as equitable in terms of medical care as well, trying to destigmatize mental health care access, we would actually be able to reach and treat a lot more people.
Sandrine, I saw you nodding as Michelle was speaking. in your social workspace, where are some of the barriers to just seeking help that you are seeing?
A lot of it has to do with cultural stigmas. A lot also from generation to generation, there seems to be this idea that, well, my grandmother may have dealt with this or grandfather had dealt with this, and then it trickles down to the next generation, what's called intergenerational trauma. It's a real issue and a big issue in our communities.
And Gabby, you specifically do work with LGBTQ youth. So I want to also ask, because I think there's an additional layer to like what that barrier might feel like. How is this presenting in your side?
Well, a few things. So first of all, we talk about mental health care, it's based in whiteness. And if we go back to Freud and Jung and all those people, so all those things were never meant for us to begin with. Secondly, it's hard to go into space, and while I'm serving the queer community, I'm also a queer person. So to go and find somebody that shares any identities with me is especially difficult, especially as youth. Then if you do find somebody that maybe it's a Black person, well, you can be affirmed in your Black identity. You may not be able to be affirmed in your queer identity. And those systems of oppression are played in Black churches and other places too. So for queer youth, specifically queer Black youth, they already have an extra layer to deal with on top of being a person of color.
So something that's coming up as each of you speak is the sense of generational trauma and also maybe generational misunderstandings, right? So my grandmother did it this way, so I have to do it this way. Or as a grandparent, I have gotten through the world this way. This is how I shielded myself from pain. This is how I was able to navigate spaces that, to Tiffany's point and Gabby's point, don't feel like they're made for me. And so I'm going to build this into my family to protect them. So I think one of my questions maybe next is, how do you identify when you have those generational traumas? Because it seems like one of the barriers is just knowing that it's happening, right? Recognizing that you are carrying on a myth and carrying on a narrative. Dr. Tiffany, I see you nodding, so I'm gonna pivot this one to you first. But I know, Kavisha, this is something you and I also spoke about, so we'll have you talk as well.
Yeah, I love that you're bringing that up, because you're right. It's become such the norm that people don't know. But what we do know is that in communities of color, there's higher rates of cardiovascular disease. And so what's happening is people think that the things that they find to be normal, they think it's normal. Oh, it's okay. This is just what happens. But yet you have higher rates of disease. So people really have to begin educating themselves on these things so that we can really begin tackling them.
I'm just going to jump in. So I definitely think that's a big issue. And I think the reason for that is probably because as we've progressed, there's more opportunities. We may have more benefits that previous generations didn't have. So I feel like we fall into this, well, my grandmother got through all of this and she had less resources than I did. So I should be able to do this as well. And I think, in prior generations, there wasn't that much access to mental health. It wasn't a known topic. So they probably didn't use it because it wasn't available. But now that it is available, I think it's important that we, like she said, we educate people on its availability and on kind of breaking through those stigmas and kind of the ideas that are holding people back from accessing mental health.
Tiffany, I want to circle back on something you noted, which was mistrust, because I think that is very important. And I think, Gabby, you also touched on this a little bit, and mental health feels like it's for white people, because actually lots of what we learn about mental health starts in whiteness. We have the Freuds, we see in public conversations and discourse that discussions around mental health are usually attributed to supporting white public figures and individuals. And then people have bad experiences, right? That mistrust comes from somewhere. I think that's a very important piece if we're thinking about where the healing starts. And so before we move past that, Kavisha, I know that you have experienced working with your own peers and noting that mistrust. What sort of stood out to you in that experience?
So the thing that I noticed from speaking to my peers was that everybody had a different experience based on their race. But what was common was that people of color, when they walked into any type of mental health provider's office, it was kind of, they felt like they were there so that the provider was there to figure out, why are you here, and like try to blame other factors on what was happening. So for example, if a person of color were to walk in, it would be like, oh, you're not actually depressed, and so let's figure out what happened that brought you here, but try to blame them or like their external factors, versus when a white person walks into a situation, it's like, oh, like I understand that like you're having all these symptoms, let's try to figure out how we got here, and like, did something happen in your life, did you experience trauma? And I feel like, so they were able to get more of that behavioral therapy, a full understanding, the openness, which allows them to then trust that provider and keep returning. Whereas people of color who are already less likely to even approach a mental health provider and get the help are now also not going to keep going back, and then will not get the help they need.
So I think the thing that stands out to me as I think about this is there are the myths that we hold, right? And we have to own that like within our own communities, we have these barriers to viewing mental health as something that is important, not only important to focus on, but is strong to focus on, right? We have a need to be resilient, and to do that in a self-supported way, and we don't view asking for help as an option. But there's another component, which is that there's bias on the other side. So in a space where there's maybe less representation for individuals of color, and then once you start getting into women of color, queer individuals of color, that representation probably gets a little bit smaller with each intersectional cut you make. There are biases and barriers at the start of the interactions. I think, Michelle, I know that you have done a lot of thinking around what are the barriers from the moment a patient walks in the door that's impacting their ability to get care. What have you seen in your experiences?
You know, there seems to be this predominant notion that still exists in the medical community about pathologizing the individual as opposed to understanding the circumstances of which their mental health originates. So for example, when we as clinicians are not actively anti-racist in our approach to our patients, we do them a disservice because we're not acknowledging the kinds of trauma that they're coming from or the systematic discrimination that they've been experiencing. And I feel like that right there creates this mistrust with the patient, because the patient then feels that they can't really tell you what exactly is going on because they feel like their experiences are not going to be validated, that their experiences are not going to be heard. And that already there sets up a dysfunctional relationship between you and your patient.
Can I comment on a few of those things?
Yes.
One thing I want to go back to something Dr. Brown said about, Black folks and people of color have higher rates of cardiovascular disease, which is absolutely true. But the reason that we have those rates of cardiovascular disease and diabetes, high blood pressure, all those things, is not because race is a health disparity, because it's not. Racism is the health disparity. Okay, so when we go back to those things, and similar to what Dr. Michelle said as well, we don't ask why. So before I was a counselor, I still work in a hospital as a respiratory therapist. So those are lung people, right? And many times I would read the chart and it would say patient non-compliant, blah, 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 blah. Never said the reason why. So you immediately add that stigma on top. That means everybody else is talking to that person, or this person is non-compliant. So when we talk about racism being a health disparity versus race being a health disparity, everything goes back to redlining and enslavement. So when we talk about diabetes and we talk about high blood pressure, during enslavement, we got what was left over from the house, if we got anything. Those were chitterlings, those were ham hocks, those were all those things filled with fat and salt. Now it's become a part of culture. Those were normed for us. So now those things are part of culture. We build it in, we eat these things. I don't eat these things, but this was a cultural norm for us. Of course we have diabetes. Of course we have high blood pressure. Then if we go back, we think that same concept when we think about redlining. What happened with redlining? Nobody could move into the neighborhoods. And because we weren't allowed to get loans outside of certain areas, that also means no grocery stores came in. That means there was no pharmacies, there were none of these things. So we're forced to buy at convenience stores and gas stations. So of course we have high blood pressure. Of course we have diabetes. Those things have been normed, and now it's a part of culture. So I just want to, paint a picture that it's not race. There's not one disease that can be traced back to genetics of Black folks. But all these things can be traced back to racism. So you do have these stigmas, and you have to be based in anti-racism. There's no such thing as non-racist, either racist or anti-racist, and we have to go into it thinking like that. And Black folks, I barely trust the system. And I worked most of my career in medical field, and now I'm in mental health. So it's no trust. We can talk about Tuskegee if we want. We can talk about Henrietta Lacks. We can go back and talk about all these things, but we have reasons not to. How do we change that around? How can we get folks to trust us? And then the intergenerational piece that Sandrine talked about, that's where the trust comes in. So we have a generation of people, the boomers right now, that will prefer to only have a white physician or a white mental health clinician because they didn't see that representation. Generation Z, they like Black everything. Everybody has to be Black because they're used to seeing it represented now. So it's up to us to make sure they can see that we exist, that Black women exist, Black queer people exist, and doing these types of jobs. I'm done with my soapbox.
No, and I think I'm going to jump on your soapbox and say, I think the other part of being anti-racist is the other nugget that came up here, which is like the right to be believed. Being believed is a privilege, right? And we don't talk about that enough when we talk about mental health. So the assumption that it comes in lots of different spaces, right, Gabby? So like the belief that I can pick up the phone and call the police and be believed and have that police officer be there to support me and not hurt me, that is a racially driven right that like does not just come to Black individuals. And I would say the right to be believed about your mental health needs is also influenced that way. If I think about the amount of times we see, even just let's use pop culture, rappers who are doing drugs, no one ever says, are they depressed? Right? Like no one ever asks that question, like, hey, like what's going on with this individual that they are numbing themselves, that they are turning to substance abuse? We don't talk in that way. We don't believe that there could be a problem. There is so I think in terms of like actionable steps, being anti-racist is not just all the things you noted, Gabby, which I totally agree with. I think there's also like removing that initial barrier. Like what would an equitable experience look like? It probably starts with, do you believe the person in front of you needs help and that there is not something inherently wrong with them, that they are not inherently criminal, that they are not inherently violent? And then how does that change how you provide them care? And Sandrine, I see you nodding, so I want to open the discussion to your way.
I feel like where I'm concerned, like Gabby mentioned something that really stood out to me when she said, as far as a patient being labeled non-compliant. I've worked in medical social work my entire career, and I see that constantly. And it's so frustrating because I see these providers who don't ask the questions. I ask the questions. And I think it's so important that you sit down with people and ask questions. And I'm not saying it has to be, a 30, 40, 50-minute conversation, but just asking simple, basic questions, you could actually find out a lot about someone and their history. And maybe they're not going to open up fully, but I think it's so, what's the word I'm looking for? It's so just frustrating to see things like non-compliant without asking the proper questions. Mm-hmm. And that goes back to the whole idea of mistrust in our communities, where now you're putting a label on someone. And that is definitely not something that many of us like.
There's a thread there that I want to pick up on, but we have an audience request that I think is actually really important. We've been using the term pathologizing. Oh my gosh, I'm not even going to try to say that a third time. The patient and Gabby, you've used this term a few times. I think this panel knows what you mean, but it'd be really helpful just as we're using these terminologies that we make sure everyone is in the same space. Could you define what you mean when you're leveraging that?
When I say pathologizing, I mean focuses on giving a patient a diagnosis versus why that diagnosis is supposed to go with that patient. For me, and Dr. Brown and Dr. Michelle and Sandrine might have a different idea, but that is what I mean if I use the word pathologize.
I can't tell if you're speaking, Michelle, or not.
No, go ahead. You can go ahead.
But pathologizing, it usually means that it's seen as abnormal. So it's seen as something that's unusual. And so what everyone is basically talking about is that when people of color or Black people enter into these different spaces, their symptoms are either dismissed or overly pathologized. A classic example of this is we refer to a healthy paranoia that you'll see within Black communities. And if they, I'm sorry.
No, go ahead.
Okay, but if they present, for example, in an inpatient unit, they may say, oh, it's paranoid schizophrenia, but the reality is within their context, it's a healthy paranoia. So that's an example of overly pathologizing or seeing something that within its context is normal and then making it abnormal.
Yes, I think, there's like historical context that actually dates all the way back to slavery, actually, where, especially psychiatrists, we were complicit in kind of that over pathologizing of the patient. For example, with the notion that slaves were supposed to be somehow subhuman, anyone who's revolting against slavery, therefore must be psychotic, must be diagnosed as being psychotic because they should enjoy slavery. You know what I mean? So it comes back from that great origin where there's this biased notion of how they believe we should act and speak and do, that they then misconstrue to make sense of our actions because they don't seem to understand the context of how we're operating in this world.
And there was, Dr. Michelle, I'm happy you mentioned that it was a disease, a pathology from that called drapetomania, when enslaved people tried to run away, yes. A doctor came up with that and were diagnosing people because why would they want to run away? Another way I see that come out is I've had patients that I see now in the mental health world that has previously gone to white clients who've diagnosed them with schizophrenia and they just mad.
Yes.
And they should absolutely be mad. I'm like, yes, it's me too.
Yes,
they should absolutely be mad. Yeah, why can't just be angry? Why do I need a pathology to be angry? There's a lot tied into that.
Thank you. I want to circle back on something that Sandrine was starting to touch on in terms of we need to be asking better questions. We need to be more thorough in our diagnoses of patients. We need to better understand who they are and where they're coming from. And I know, Kavisha, when you and I connected, this also came up in terms of there's a difference between being able to just get in the door once and then actually getting long-term care. And I think that there are systematic reasons why long-term care is really challenging and why we have why people of color, and unfortunately people of color, especially those with less socioeconomic resources, then experience the one-off, I'm quickly diagnosing you or I'm quickly moving you through the system. I know, Tiffany, Michelle, you've both spoken a little bit about just like how insurance works and how the actual process of getting access to care creates disparities. And so I want to talk about that because I think it's very important to understand that it's not just the people. There are well-meaning doctors who care a lot, who want to help their patients, and there's a system that is not built to allow that to happen in a productive way. Tiffany, I will pass it to you first.
Yeah, I mean, it's really unfortunate, but how systems are set up is that, for example, I'm a psychologist and reimbursement is not that well. So what you have is a lot of psychologists or a lot of therapists who do not elect to take patients who receive insurance. So then you have some of these very capable therapists who people often can't afford to see because insurance companies aren't reimbursing the therapists a decent amount of money. So it's a war that happens between providers and insurance companies, and then unfortunately, who gets hurt? It's the people.
Gabby, I know this is something that you were thoughtful about in your practice.
Yeah, so in my practice, I don't take insurance for many of the same reasons Dr. Brown laid out. Another reason is that if I did take insurance, I would have to give the patient a diagnosis the first visit in order to get reimbursed. I don't find it ethical. I know it's a thing, and I know it's helpful to some people. I know that folks are okay with having a diagnosis, but I don't think 90 minutes is enough to come up with a ethical and equitable diagnosis for a patient. So I purposely did not do that. And I'm hoping to just, have a few full pay clients so I can offer sliding scale, low fee sliding scale for the rest of them for those same reasons.
Gabrielle, I love that you mentioned that. And that is one of the ways that a lot of therapists work around the system. If you can have a handful of people who pay full fee, then what happens is you can offer services to people who can't afford the full fee. So a lot of people, when they're looking for services, they don't know that, but you have to ask the therapist, do you have a sliding scale? And if you do you have any spots available?
Yeah. Can I just touch on something that Gabrielle said that I really appreciated? It's, the initial diagnosis that you give a patient within 90 minutes of meeting them. And I do agree with her that it is inherently problematic because one wrong diagnosis, no matter how well intentioned, will follow a patient around for the rest of their medical and mental health life. And it is such a disservice because then you run into these patients who have been poorly mismanaged by either well-meaning intentioned providers or people who just didn't have enough caring to go beyond the surface of whatever their clinical file presents. For example, it's already commonplace to see that for African Americans, when they're presenting with very depressed, displaced kind of symptoms, they're more likely to be considered schizophrenic or exhibiting signs of negative schizophrenia as opposed to just true depression. So once those labels start to pile up on that patient, then it starts associated with all these other unnecessary treatments, unnecessary medication that is actually detrimental to them in the long term.
Keisha, I want to tag you in here because I know this is something that you have sort of experienced and feel really passionate about. What is your sort of vantage point, Ben, on the diagnosis and long-term treatment options available to patients?
So just to touch back kind of on the systemic, I think definitely the insurance and all of that definitely plays a factor into it and is a big issue that could be worked on. But I think even from what you said with the providers, because I feel like providers don't understand where people of color are coming from and their background. And like we talked about, the other stereotypes and kind of the things that we have to go through to even get that care, we kind of don't get long-term care because, one, we don't feel like we're accepted by our providers. And then also there's other barriers that providers don't usually think of that people of color face. Like, for example, I may not be able to come to your office at this time, this many times a week, because I don't want my family to know, or my family doesn't support me seeking mental health care. I may not be able to get the prescription that you prescribed. And now that you're deeming me as uncompliant with my medications, but it was because I didn't have access to I wasn't able to get it because maybe I'm on my family's insurance and I don't want to tell them, or they, again, don't want me to take the medications. And so I think these are things that providers need to be more mindful of and understand that are different in people of color versus their other patients.
I'd like to add to that a little bit, if I could. Also, I think it's important that providers as well, this is what I totally agree with you. And also on top of that, the work that has to be put in just to find a provider, that in itself is so challenging. It's so overwhelming. And as a person of color who's seeking a therapist, they're already having this struggle, this internal struggle about doing this, and then this idea of now having to put in so much work just to find a therapist, I think has to also be at the forefront as well.
I think populations and not population, geographical location plays into a lot of that, especially what Sandrine was saying. I live in Idaho, which is likely the whitest place on earth. And right now I'm living in Idaho, and I've been here for years, and I looked for a counselor, and I shopped. I used my EAP, and I shop for different counselors, and I found them all problematic. I couldn't go to a Black counselor because only 7 existed, and I knew them all because the community is so small. I only happened to find a counselor because she was a school counselor, and she quit and opened her private practice, and I hurried up and became her client before I become her friend. So I think that plays, an additional barrier. And that's all, the reason why I switched personally from agency to a private practice. So I could offer those evening hours, certain days of the week, or super early hours, because a lot of times communities of color can't afford to take a day off to do these things. And it has to be sometimes at 7 a.m. or 6 p.m. So I think, again, geographical location plays into it as well.
Gabby, I'm going to keep you on the hook a little bit because Kavisha brought up a really important point in terms of barriers to engaging in therapy that are not initially seen or thought of. And to be clear, I don't actually know that just is a people of color challenge, right? Like I imagine women seeking therapy if they're in a domestic situation, regardless of their race, have to navigate, does my husband know that I'm talking to someone, and like, how do I shield this? So I think in general, this is probably something that is a challenge and a barrier for anyone receiving care, but then presents itself in very specific ways based off of cultural background and or being a queer individual. I know, Gabby, that you have noticed some changes in how you've had to support some of the youth that you counsel, especially given COVID. Can you talk to us a little bit about some of those barriers that are coming up now?
Well, COVID is a barrier to everything, so I do want to point that out. So we're seeing more for me specifically. I work in the hospital as a respiratory therapist, but outside of it, as a counselor. So those are two separate entities. So now you have a group of kids who felt safe at school, which is not normally the case with queer youth. But with this newer generation, more people are affirming and accepting. So now the place of danger is home, where they're stuck at because they're not going to school anymore, And then if they're at home and the parents are supportive of counseling, well, now it's telehealth. Maybe they don't have a space, likely because of redlining, where they can go and have a room to themselves, where it's quiet, where you can have this sense of privacy to talk to your clinician. I know my appointments have changed with clients I was seeing on a regular basis, and they were able to be pulled out of school to participate in counseling, and they're not able to do that at home anymore via telehealth. Not because they don't have a computer, just because they don't feel comfortable being honest anymore with having parents or siblings around that they distrust. So it's not just outside of the home that makes receiving care problematic. Being inside of the home also can be a barrier to communities of color, especially the intersectional pieces of identities receiving care as well.
So I want to pivot us a little bit into an audience question. We've been talking a lot about the care that individuals, communities of color receive. And specifically, one of the things that's come up is the need for representation and within the person delivering your care. That said, I think, Gabby, to your point, like location makes a huge difference, and not just location, right? All the other barriers we talked about. Who is your insurance going to cover? Like, if you don't have a free-for-all pick, and especially if you require insurance in order to afford that support. So one of the questions that's coming up is, yes, it's great to focus on increasing diversity, and we should do that. We should make it more accessible for students of color to enter these fields and to succeed and to have their own practices and do great work. But also, there's still going to be lots of people of color who have white care providers. And it's not awesome if they're still receiving a not anti-racist care. And so one of the questions is, what do we do about it? I want to start with one specific question, which is, we have an audience member who noted that their program has really focused on implicit bias training as a way to navigate this challenge and to recognize and remove unconscious biases. They'd like to know the panel's view on how effective implicit bias training actually is. I think this is an important question because this is a very commonly used tool. What are some of the pros and cons? Gabby, I saw you smiling the second I said implicit bias training, so I'm putting you in the hot seat.
You know what? The thing is that the word training is what's problematic, because when people receive a training, they think at the end of it, oh, I'm good. I went to anti-racist training. I'm no longer racist. And when we talk about implicit bias, we all have them, and a lot of people have trouble, accepting those things. But the goal is to be able to shelf them to serve the people you're with and still work on them separately from the person that's in front of you. So when I giggle, it's because people think like, oh, let me just do this training, it'll be helpful. What it should be is a continuous education. When we try to go to cultural competence, there's no such thing as cultural competence. Competence is a journey. None of us will ever be completely culturally competent. We're just on a journey. Same thing with allyship. Same thing with being anti-racist. It doesn't end. It's just a continuous journey that we know we'll never get to the end to, but we still have to do it. So I don't think it's about training. It's just providing continuous education about different people, especially through an intersectional lens per se.
Sandrine, what are your thoughts on how implicit bias training can impact outcomes when working with white providers?
I think it's just important, like what Gabby said, it's not just a training, it's an ongoing conversation, it's an ongoing act. It's, not just a one and done kind of thing. I think everyone has to talk about it, and not just in the work setting. It has to be talked in the family setting. It has to be talked about, in your colleague setting, like just everywhere, just constantly talking about it. I think that's so important.
Michelle, so let me ask you, if you were looking at a white colleague and they were wondering, what's one thing I could do to be better in this space? Like, I care, but I think I might not be hitting the mark. What would you recommend as a starting point?
Well, that's a good question. Usually the biggest thing I would tell them to do is to seek out places that make you uncomfortable. And I use that within reason, as in finding people that you normally don't talk to and actually having a normal conversation with them, and asking them, what are some of the things that actually keep you up at night? What are some of the discriminations that you've experienced? How has that impacted your life? It's really more about you having to step outside of your own comfort zone to understand, or at least get a notion about how other people live their lives. Even though you guys come to the same space every day for work, what I had to deal with before I got to work is completely different from whatever you had to. And so being able to share my story without judgment to a white colleague of mine is something that's so crucial.
We have a similar question with a different take. So Dr. Tiffany, I'm going to pass this one your way. Someone would like to know the panel's views on unconscious biases, specifically as it applies to sort of transference and countertransference. So if we're thinking about how does unconscious bias impact those two topics, what are your thoughts on how, and I think this specifically is coming from a space of, again, how do we shield ourselves from the negative impacts of these? What are your thoughts on what an individual could do to recognize unconscious bias and understand when transference and countertransference are occurring? And probably define what you think those things mean, just to make sure everyone in our audience is on the same page.
No, that's a very loaded question. When we talk about transference, that is the patient's feelings towards the therapist. When we talk about countertransference, that is the therapist's feelings towards the patient. So hopefully that makes sense to everyone. That's the simplest way of being able to explain that. And when you talk about countertransference, often therapists will use that information in order to be able to help their patient. So for example, if I'm sitting with the patient and it starts to feel like, oh man, this person is being demanding of my time, or this person is they're crossing different boundaries, then I can use that information as an assessment of how they may be operating in their external world or in their world. So if you have different biases that you haven't faced or you haven't dealt with, it can easily impact how you are assessing the patient and how you are treating the patient. So one thing that is always encouraged with therapists is you have to begin to analyze your biases. You know, I heard a very experienced analyst say one time, have you had your racism analyzed? So if you're not checking that part of you, it will very much interfere with your assessment of the patient and your treatment of the patient.
So I want to dive a little bit more into the transference question, because I think we've talked a lot about individuals of color have real reasons for having certain feelings. And so when we think about, as a patient, I might feel biased against my white doctor, or I might feel like they're not understanding me. I might feel like they might hear me. There's probably a very fine, challenging line around when is that me having a bias and assuming that a provider is not hearing or seeing me or has a bias against me, and when am I actually having a very real reaction to the care that I am receiving? If you were counseling when I say peer, I mean like a friend who is going through maybe vetting out a therapist, how would you help them navigate that? Maybe that feeling of like not trying to self-gaslight, right? Like if you really don't feel like you're getting great care, we should advocate for yourself. But we also want to be thoughtful that we are all coming in to those scenarios with our own biases. Tiffany, I see you nodding along, so I'm going to sort of pass this question back to you and say, how do you navigate transference with patients of color working with non-POC providers?
This is what I tell anyone who asks me they're looking for a therapist. Go to someone that you're comfortable with. And if you can't find a therapist that you're comfortable with, what I encourage them to do, for example, when Black people email me, if my practice is full, I say to them, I know some people who work well with people of color. Here, check them out. Do basically like an interview type situation. Call a few of them, get a feel for them, and then make an appointment. If it's still uncomfortable, then hey, come back to me. So find a therapist, and I do this for anyone who emails me. It's like, it's not a thing for me. It's kind of like one way that I say I'm supporting the community. So find a therapist in your community. If it's a person of color that makes you feel more comfortable, ask straight up, do you know some other clinicians who are comfortable working with people of color? Or do you know some other clinicians who, you know, who have experience with this? Can you refer me?
Dr. Michelle, are there other recommendations you would make to empower people to be their own self-advocates and to be thoughtful in the level of care they're accepting?
Yeah, I would really advocate that my patients ask questions, because the biggest detriment to patients' health, whether it be medical or mental, is that they keep their questions to themselves and they never question their treatment. Like, as a doctor, as a physician, I am on your team. It is you and I that are collaborating to get you the best health that you can get. And so if I don't hear anything from you, I'm taking that as as kind of like a quiet acceptance of that you agree with my therapy, as opposed to asking questions about how that therapy may impact your life, or if that therapy may not be very helpful for you. And so I think it's really difficult because some patients, especially patients of color, do not feel necessarily comfortable speaking up for their own, about what they experience when they're in the healthcare system, whereas other, racial groups feel totally comfortable and privileged to not only question your therapy but challenge it. Yeah.
We're getting a few audience questions on just improving diversity in the mental health care field. One specifically notes, I'm a white autistic non-binary psychology undergrad and an undergraduate admissions worker. Sadly, the health field was built to work better for white professionals and students, and currently in the US, a large majority of mental health professionals are white. My question then is, how can colleges and employers work to include more students, professionals who are people of color in their programs and workplaces, especially since, and I think as we've talked about, at the end of the day, patients of color currently have better outcomes with providers of color. Kavisha, I'm actually going to bring this question to you because you're currently a student, and I would love to hear from you what you have benefited from or what you would like to see in order to improve inclusion.
So one of the things that I would definitely like to see is kind of normalization of mental health for people of color, and like education to understand that it is okay to feel a certain way and it is okay to seek help, and education to break down those stereotypes that are in like the kind of the things that we already have ingrained into us as part of who we are, that prevent us from accessing mental health, and like the stigma associated with it, particularly for people of color, as well as, like we mentioned before, more access to resources like outreach, and kind of a wider range of available resources. Like, if you don't feel comfortable with this provider, here's what you can have as a student. The mental behavioral health program has 2 providers here at UConn. So you're very limited in your options. So if you don't like a provider, where do you go? And so education, outreach, and definitely access to more resources.
I want to touch on something Kavisha just talked about, because I think when we started this, we acknowledged that within communities of color, there are these biases and barriers and generational myths. Kavisha just sort of noted, like, one of the ways that we get more individuals to engage in careers around mental health is that you've got to get rid of those things first, because if you're not willing to ask for help, you're probably not also thinking of this as your career of choice either. So my question for the panel is, how do we do that community work? What are the recommendations for changing the community belief and behavior around mental health and sort of breaking those generational traumas that continue? I know this is a big question, so we might not have an answer, right? But it's something that is core to changing the willingness to engage either as a patient or provider in the mental health system. Michelle, I'm going to pose this to you, but maybe I'm going to flip it and say, like, you broke through that barrier, right? You are currently in a position in which you value mental health and provide mental health support. So what gave you that pathway forward, and what was helpful to you in that space?
That's a good question. To be perfectly honest, I had a role model. And my role model was my mom. So my mom works in Dallas County as a juvenile counselor for drug addicted youth and teens. And so she was always an advocate for mental health care, for understanding that the child, they're using substances because of an underlying crisis, not because they are inherently pathologically bad or evil or good. So seeing my mom do that kind of work was really inspiring for me. And then having those role models who encouraged me that, I can go to med school, I can go into psychiatry, that is a pathway that's an opportunity for me, was really crucial. I would say, especially around about college time, it's very easy for you to become discouraged going down that particular pathway, because becoming a psychiatrist is a lot of difficult work. And there are many avenues for self-doubt. And unless you don't have if you don't really have that role model there to help guide you through that pathway, you're apt to leave and not be able to be participants in the mental health care system. Yeah.
Sandrine, what are your thoughts on how we better educate communities and begin to break some of the myths that currently keep people from engaging?
I really believe, I feel like I'm like the broken record, but I think communication, just talking about it, we have access to so many different tools with social media alone. I mean, there's been this big push. I really think Gen Z are like they have so many tools and so many people to look up to in the virtual space that really promote this idea of mental health. And it's so important, in addition to that, self-care, because all of these things that we were taught, or many of us have been taught to kind of, push through or pull up those, bootstraps, as we were saying before, and not having that opportunity to really focus on those things. But now we have this accessibility to talk about these things in a more, bigger platform. And I think that really helps. And maybe providers themselves can also, push, add on to that. Just keep on talking about it.
So I love that yes, Tiffany. Go for it.
I was going to add to it very quickly. I do think it's important to talk about it more, just like Sandrine was saying. But another thing is we also have to go out and meet the community where they are. So one thing that I found that's important for my practice is going into churches, because there's older people there, there's people of color there, and talking to them about mental health. So it's actually bringing it to them and being able to say, oh, when your stomach is hurting, you might be actually anxious. It might not be something else, but it's taking the education to them as well.
Tiffany, I love that you said that. When Sandrine was speaking, the thing I was going to say about social media that I think is really valuable is that it brings access to conversations around mental health to individuals who might not have had access to it just in otherwise. So the ability to hear a conversation about self-care, have someone even share some of the things that they're learning in their therapy sessions, that allows you to think about that. But I think, Tiffany, my question was going to be that ultimately social media is working really well for our growing generation, and that is hopeful. And I think we all need hopeful things, and that feels really good. But it does not address the people who are not engaging on TikTok. And so hearing you say that the other piece of this is going into those communities, I think is really important. And I think sort of speaks to what Michelle was saying in terms of, if you are a white provider and you're wondering, how do I change this narrative? Like, go to where you are uncomfortable. Also, there's probably opportunity for all providers to be going into communities and better supporting. Gabby, I know that you do a lot of work with I don't know, Gen Z, I don't know what, I actually don't know what alphabet we're at right now. But what are you seeing in terms of trends that are maybe positive in how we're thinking about mental health within communities of color?
Similar to what Sandrine said, they're talking about it. They are making it, they outwardly talk about a diagnosis they've received. They say things using I statements, I feel anxious. And those are normal things I get to hear when I'm in these communities. There's no hiding. There's no I don't know if I should talk about this. And they're bringing other people. I find myself similar to Dr. Brown, working in the community, going out and spending time and doing this work. And just like Dr. Michelle said, we do need more representation, and people should attempt to talk to other people with different identities. However, they should do that without constantly extracting free emotional labor for that, especially because we have Google. So we have those things too. But the young folks are saving the world. I mean, look what happened with the election in TikTok, with some of these rallies. They were able to get a rally to be almost empty by using TikTok. The power in that, and it's free. How come we can't capitalize off the same energy from them? At this point, this panel should be filled with all youth. How do we break the system? How do we fix it? But they're just talking about it. They're talking about it in every space possible.
I want to sort of bring up a flip side to sort of the social media and the access, which is right now more than ever. I'll speak for myself. It also feels like that access leads to external exposure to trauma. I this year alone, I've watched more people of color be violently murdered or violently treated in a way that maybe years ago we would have had the one news story, but not in the way that it is this year. And to be really clear, that is a positive, and that it's what has pushed change forward. We are hearing about it, we are seeing it, we are writing about it, but it's my suspicion that constant exposure to those external traumas has its own backlash. So I want to sort of ask you, as we're starting to come to the end of our time, a two-part question. We'll start with part one, which is just, what has the impact of 2020 been on the mental health care of individuals and communities of color from your own personal perspective and experience. And Michelle, I see you shaking your head. So I'm going to start with you because I also know that we are both in two states that are not currently handling COVID well. So on top of racial unrest, we are navigating a lot of pandemic hurt.
Yeah, it's a really good question. I think, as you stated previously, it is a double-edged sword, because while knowledge is power and it allows us to be empowered in our actions and our decisions to protest for our rights, to advocate for our freedoms and our equitable treatment under the law, it also comes with a lot of trauma. And you have to realize, watching somebody be murdered in front of your eyes, that is a secondary trauma that sticks with you, and it gleams onto you, and it weighs you down. In 2020, apart from the deaths from COVID, and then all of the civil unrest and the racial injustices that have been levied against us, and the voter suppression, all of that is a trauma that constantly adds up, and it manifests in anxiety, irritableness. You're feeling more cranky, you feel isolated and alone, you feel like no one is actually paying attention to you or actually values you as a person. And so every other interaction that you have with somebody that isn't, another person of color, feels tense because you're waiting for the other shoe to drop. And I think that if you don't find a way to be able to step back sometimes, no one is requiring you to be the only advocate for mental health care in your entire community. You cannot be that one person who's constantly being the rally cry for everyone else. You can point attention to what needs to be paid attention to, because at the end of the day, you have to take care of yourself. And if you can't take care of yourself, you're going to get burned out, because advocating for your rights is a long, continuous, ongoing process. And you are not the only person that is meant to carry that torch alone.
Dr. Tiffany, your thoughts?
I mean, 2020 it's really having a detrimental effect on people's health. And it's not just the COVID. Gabrielle was speaking about this earlier. When you have higher levels of perceived stress or perceived racism, then you do have also with that higher levels of cardiovascular disease, higher levels of depression. And that's not even getting into the financial issues that people are having, because we know that when people are financially strapped, they're not eating as healthy. And there's already not grocery stores in their neighborhoods. So it's so complicated, but 2020, it is, we're seeing it everywhere. Like, my practice is basically full at this point because people are just running in because of everything that is going on. So like Dr. Michelle was saying, you have to find ways to take care of yourself, whether that be stepping away, whether that be finding ways to exercise more, getting more information. If you can't afford individual therapy, get in a group. If you can't afford a group, get in a meditation circle. But you got to find a way to take better care of yourself.
Keisha, your thoughts?
Yeah, so like we talked about, I think 2020 has definitely opened a lot of doors in terms of mental health, and has increased awareness across the board. But it didn't change the fact that people of color at baseline still have a lot more barriers. And so even though I think everybody may have gone from 60 to 80% in terms of mental health awareness, seeking care, we're still kind of, everybody else went to 80, and then we're still at like the 70%. Like, there's still those barriers that won't change regardless of the situation. I think that has to change systematically with providers and education.
Sandrine, how are you seeing 2020 impact your community?
People that never would have considered therapy are actually actively seeking therapy. And I think it's phenomenal, because obviously they're addressing a lot of issues and all that has been happening. But also what's happening is all of that has happened in 2020 has also brought up a lot of other stuff from the past. And I think there's just so much trauma. And I'm just grateful that people are now realizing that there are ways to prioritize your self-care, whether it be through therapy or meditation, support groups, virtual groups, obviously, all those things. I think it's really awesome.
And Gabby, we're not going to let you off the hook here. What are you seeing, and how are you also seeing people navigate the new challenges?
Well, I think 2020 was trash overall, but we did have some good things. In Idaho, with it being less than 10 Black clinicians, my practice filled within a weekend. The spots I had open filled within a weekend, but that also presents another barrier to those clinicians, because now you're trying to meet the needs of the community now. So I think I'm more worried about how are the clinicians handling the increased burden of supporting people that look like you. And that goes again back to the transference, counter-transference question that was earlier. I'm interested to talk after that, to see how it goes after that, how those clinicians partaking in those same meditation circles and group therapy and individual therapy and self-care as routine versus as a one-off massage. I'm interested in those things. I think 2021 will be interesting. It's depending on what happens, we'll change the level of interesting we're looking toward. But I'm looking forward to 2021 and seeing how we all come out on the other side.
Gabby, I love ending on the note of self-care as a routine, as a consistent practice, because I think many of us here, and I see here in this room, but here in the audience, are probably in positions where we're providing emotional labor. And we say that term, sometimes we mean it negatively, but there's a positive way, right? There's a positive way to give to your community. Every single person on this panel right now, you have given me your emotional labor by being present tonight and talking about this and sharing yourselves. And so I want to just acknowledge that publicly and say thank you. And that means that the self-care loop has to be continuous and ongoing. You pour into someone's cup and you need to get your cup refilled. You wake up every day and know that your existence is your own sign of resistance, and it gives you the opportunity to take care of yourself. And I'm taking a lot of heart in knowing that we have a generation of individuals of color who are at least having the starting point to knowing I need help. There are barriers, and we talked about them. And I think we talked through a lot of interesting and productive solutions for moving past those and moving towards an anti-racist, inclusive world. But just that initial step of I need help, and I need community, and I need support, whether professional or through your friends, your families, is really important. And so I'm hoping that everyone here tonight has walked away with something actionable that they can do within their own space, within their own practices, within their own schools, to allow us to continue this focus in 2021, because to Gabby's point, we will need it. I want to thank everyone tonight for joining us. I want to hope that everyone out there is taking care of themselves, and I am wishing everyone a good evening. Thank you.